Hello and welcome back to another episode of the EP Growth Podcast. I'm your host, Ryan McCarthy, the director at Hunter Rehab and Health, and I'm joined by a very, very important guest, Blake Withers from Achieve Podiatry. How are you going, Blake?
Mate, I'm doing well. That's a big intro. I feel very important after that. So it's great.
Yeah, well, I think it's well deserved, mate. You're definitely highly regarded in my books and in the EPs that work in the clinic here, and we're absolutely pumped and excited to have you on the podcast and share your 2 cents and your perspective from that podiatrist point of view. I think it'll add a lot of value.
Yeah, man, I appreciate it. I just wanted to ask, I was going to ask you off air, am I the first podiatrist to come on?
100%.
Oh, dang, that's going on. I'm texting mum and dad and telling them that. First spot on the EP podcast. That's awesome. That's cool.
Awesome, mate. Let's dive straight in. Give the listeners a bit of a background, mate. How did you, first discover you wanted to be a podiatrist, and tell us where that all began.
Yeah, I'll give you the elevator pitch. I didn't originally want to do podiatry. I didn't really know what podiatry was in school, but my coordinator, the person that does the jobs at the school, just mentioned, "Have you thought about podiatry?" This is in year 10 or 11. Didn't really know what it was. Went to year 12, got the mark. I think I got maybe like in the 80s. I could do pharmacology or podiatry, but I wanted to do physio. And I thought, nah, I'm not going to, don't have the marks for physio. I'm going to do pharmacy. And then got to 2 weeks before enrollment and thought, nah, I think I'll do podiatry. It looked pretty cool. And then went through the first couple of years and really kind of enjoyed it a little bit. And then I met my now mentor and boss, Justin Smith, who kind of showed me what podiatry could be in the sense of specialized foot and ankle musculoskeletal health, really helping people from the foot and the ankle level. And then the kind of passion grew from there. So it wasn't a one thing that I always wanted to do, but then once I got into it, I was like, this is awesome and absolutely love it and haven't looked back.
Yeah, that's awesome, mate. I think it's strange, isn't it, that a lot of us, aim for that physio. I think a lot of EPs aim for physio and then fall into EP as a result. But I think potentially it's because physio is so well known. Do you think with podiatry, there is an issue in high school or early years that it's unknown?
Yeah, certainly. I mean, I have times with patients where they kind of ask, what I do, and sometimes it is easy, and I'm sure you guys can sometimes have the same issue. I'm like, yeah, I'm like a physio, but for the foot and the ankle. I'm like, oh, okay, you do all that stuff, but for the foot and the ankle. So I think high school, it does come back to people just not understanding what podiatry is, and also probably not understanding the musculoskeletal aspect and sports aspect of podiatry, because most people, when you think podiatry, you think, cutting older people's toenails and skin and nail care and that kind of it, where it encompasses a whole lot of diabetic care, orthoses, pain education, rehab, footwear orthoses, research, biomechanics, that kind of thing. So probably hoping to get people to understand this big aspect of all different things podiatrists can do at the high school level, hopefully.
Yeah. Good point, mate. Excellent. So just run us through a normal day for you, mate. What does it look like? From start to finish in a normal day in your clinic there at Achieve.
Yeah, so we're at Achieve Podiatry. I work for Justin Smith here at the stadium. So at our clinic, myself and Justin, we work alongside a bunch of sports doctors and sports physicians. So an average day looks like roughly 9. Love the late start. Any advice if you can get a late start, get a late start. 9 to 5:30, and predominantly just dealing with chronic musculoskeletal foot and ankle conditions. So see generally 5 to 6 patients in the morning, an hour for initials, 30 for follow-ups, and then generally 5 to 6 in the afternoon. So lots of Achilles, forefoot conditions, plantar heel pain, arch pain, lots of runners, and lots of kind of, I guess, chronic conditions where people have had, foot and ankle pain for 6 to 12 months, and they've tried a lot of other things. And then someone said, hey, you've tried all this, going to the guys that Achieve, and we're kind of managing them in that phase. So anything foot or ankle, and a little bit of nail and skin care, like ingrown nails and corns and callus and blisters and some ultra runners and things like that, but predominantly musculoskeletal foot and ankle conditions.
Yeah. And would I guess, the majority of new clients that come into your clinic, would they be referred by GPs, specialists, or is it word of mouth around town? Is there any marketing involved? Where would the majority of those new clients come in and see you guys?
Yeah, great question. Predominantly, it just comes from like other patients, word of mouth. Certainly, the online space. I mean, as a business, you need to have an online presence now because everyone else is online. So a lot of our Instagram and website, and a lot of the time from other referrers, so physios and sports doctors and surgeons and EPs and things like that, where in most cases, foot and ankle conditions can be managed and everyone can manage them. We generally come into play a little bit more when someone's kind of tried everything else. So say for an easy condition that lots of people see, Achilles tendinopathy, they've tried all the rehab and they've tried everything, all the good, I guess, first line therapy, and things aren't working. They might, get referred to us and then look at heel lifts and shoes and shockwaves and a little bit more nuance, with the rehab or kind of to help what they're already currently doing. Yeah, so we work a lot with other referrers.
Mm. And is in an ideal world, do you wish that you could get them a little bit earlier in that treatment timeline? Like, is early intervention going to make your life a whole lot easier?
Oh, certainly. I mean, from what we understand with the research about, pain and certainly how people's systems change in response to long-term pain, things generally get better quicker if it's only been going on for a shorter time. And like we know that from the research, the longer something goes on, generally the longer it takes to get better, the more down people are, the more other fears and beliefs they have about it. But if I can see plantar heel pain at 2 months in compared to 12 months, it's going to get better a lot quicker, certainly, in most cases.
Yeah. Yeah. So I think, we need to, just continue that education to any of those referrers to keep an eye out for any of these little triggers to get them across earlier. It's going to make life a whole lot easier. Obviously, you're teaching at the university as well, and research is really important to you, I guess. What are you currently doing, and what's the best way for yourself as an allied health professional and podiatrist to keep up to date with all that research out there?
Mate, that's such a tough question. I mean, I feel as though if you could answer that, you'd be a billionaire if we figured out how someone can live the life they want to outside of work, be a great clinician, be a great partner, be a great friend, and also keep up to date with the research. You're always juggling those things. It's incredibly difficult. I'm quite lucky, like my partner's a physiotherapist, so we talk a lot about this stuff, but my day generally looks like patients, and I come home and probably I've got a social media and a podcast as well. I probably spend 2 to 3 hours every night looking at research, creating content, reading things, and doing stuff for the university. And it's probably not as sustainable at this stage in my life, and I probably wouldn't recommend that for people. I think the best way to do it is you need to follow people that you trust and think have a good nuanced approach to it. So people like, Greg Lehman, Adam Eakins is really good. Ben McCormack's really good. But myself sometimes. But people that are spending the time and trying to present that nuanced information is probably one of the easiest, lowest hanging fruit. And then also trying to evaluate it yourself. I mean, just reading papers and understanding how that translates clinically, you can only get better at it the more that you do. It's just making the time and the effort, but it's difficult. And you're not always going to want to sit home and read research, but it's something that I think at this stage of my career, and that might change in a couple of years, I do think it's something that you have to do as a clinician because things are changing all the time. We think of manual therapy, even in my space, how orthotics work, how to treat Achilles, how to treat plantar heel pain. These things are always updating. Certainly the principles of listen to your patient, therapeutic alliance, patient-centered care, those things generally stay the same, but there's little nuances of the treatments that kind of change. And if you're staying up to date with that, generally it's going to help you get better outcomes, I think.
Yeah. Yeah. Great point, mate. Just in regards to that, let's get granular. You mentioned following professionals on social media. That's one way. Obviously, they will summarize papers and present it in their way. So following those professionals that you trust. But then when you mentioned as well, you go home and you do a bit of research, like exactly what does that look like? Are you jumping on Google Scholar? Are you jumping on other journal platforms? Are you following certain pages on Facebook that present articles? Like what does that actually look like in terms of that research?
Yeah, like that's a great question. I say this from my point of view, which is very easy, and sometimes I forget this. Like, because I teach and lecture at the university, I have access to all the papers. I can get a full paper very easily. For most people, you can't do that. You can only read the abstract and the results, so it's quite difficult. And I haven't met anyone, and I don't think I ever will, that's going to pay $42 for a paper and do that a couple of times a week. And there's a couple of websites where you can download them, but for me, it looks like coming home, I've got a couple of really good journals that I follow. So last night Journal of Sports Medicine, Journal of American Sports Medicine, British Journal of Sports Medicine, Journal of Footwear Science, and the Journal of Gait and Biomechanics are my go-tos at the moment, where I'll just have a look. Every so often they bring out a new issue, which is generally between 10 to 20 articles, and I'll just have a scroll through there, see what's interesting is one. So I've got two aspects. One that I find really interesting that I'll just read in my leisure time. On the other side, I'm like, what stuff that's going to help me as a clinician that I might not want to read, so I can try and push against my biases. So as an example, there was a really good one recently that was looking at custom orthotics versus non-custom orthotics for big toe osteoarthritis, and found no difference. So it doesn't really matter what you use. Of course, there's issues with those kinds of studies, but something like that probably doesn't sit well with too many podiatrists, but you've got to find research that goes against what you believe. So find stuff you like and then find stuff you don't like. And that's the best way to have a nice, well context approach to talking with people and patients as well.
Yeah, such a great point, mate. As health professionals, we cannot be stuck in that fixed mindset. I think we really need to be that abundance mindset and be open-minded, because the second we become fixed, then research changes and we're outdated.
It's hard, and like it's so difficult because we say all these things and you see people say all these things with such conviction, and then there's so many studies to go against what people say. Like one that's been huge, not sure you're aware of it, that's come out recently looking at the GLAD program for knee osteoarthritis versus saline injections. They both got better, but found no difference. So you can inject hot water into someone's knee, and that's just as effective as giving someone an exercise program. Like that goes against everything that I believe, and I'm sure most EPs would believe as well. But it just shows, I don't know what it shows really, but it just shows that things are probably not what we expect all the time.
Yeah, I think it shows we don't know what we don't know. I think that's what it shows. There's still so much we don't know. And I think if we accept that, then we become a bit more comfortable in who we are and what we do, and sort of relieve ourselves of that stress, I guess, of trying to feel like we need to know everything. Something might come around in a few years' time, like, oh my God, how do we not know that?
Or like this happens, but just completely opposite to the way in which we thought it did.
Yeah, exactly right. Awesome, mate. I think what's I'm a massive fan of is that EP and podiatrists, I feel like they have the biggest crossover out of any allied health professions, in the fact that they treat very similar patients. And what I wanted to ask you was, from an EP perspective, we have initial assessments. They go for 60 minutes. A lot of younger EPs are so focused on just getting through that process and doing their own assessments and getting them to buy in, that they're not even aware of referring out or thinking when a podiatrist could actually help. So I guess if we've got an initial assessment with a certain patient, what are some of the triggers that should go off in our head to go, that's a great patient to refer across to Blake or to a podiatrist?
Yeah, that's a really good question. An awesome term that Justin coined. I guess if you can imagine a pyramid upside down, so you've got the big one at the top, then smaller, and down at the bottom. At the top, I think we might have talked about this before. At the top, you've got your kind of identifiers, and then down the bottom, you've got your diagnosticians, and then right at the bottom, you've got people that give treatment. So you think of where you sit into that pyramid. Most people, when we're screening it and seeing patients, we might be the identifiers. So as an EP, as an example, someone might say, I've had this chronic plantar heel pain for 7 months. They might be seeing you for something else, but I've had this heel pain for 7 months. It's not going away. I've tried injections. I've tried all these things, tried medications, tried resting, and it's not getting better. You can identify that. And then diagnosticians, you can get a pretty good idea as to what it is without officially diagnosing them and saying that. So you've identified it. We would be the diagnostician. So you're like, it sounds like you've got chronic foot pain. You've tried everything else. It might be beneficial to try podiatry. They see this lots of the time. You might need something soft. You might need a little bit of offloading. And then they would see us. We would be the diagnosticians, and then also give the treatment. But I guess as an overarching term would be just chronic foot and ankle conditions where someone has tried lots of the good things already. So if someone comes in, with arch pain they've had for a month, not everyone with foot and ankle pain needs to see podiatry, because lots of people with foot and ankle pain get better all the time without seeing podiatry. we probably are most effective where it's been chronic, long-standing, and they've tried everything else. So they've been physio, they've seen the GP, they've seen the surgeon, they've seen the sports doctor. They're like, I've done everything, but I haven't seen podiatry. That's probably a good one to refer on, because we can just play the game of arts and crafts with inner soles and shoes and taping and a little bit more education, a little bit more nuance with how much time they're spending on their feet. So one thing to remember, I would just say chronic foot and ankle conditions that have tried everything else.
Yeah, perfect. I think that's a great summary, and something for all listeners to be aware of as soon as that that's come up in the topic, or it's even a question to ask as we're going through their aches and pains. Then it's something to think about, that trigger to refer on. Awesome. I guess when an EP does refer across and you're co-treating with an EP, what is the best way to keep in contact with yourself, I guess, from a podiatrist? Like I said, you're seeing clients all day. What is the best way to update you with how they're going within their EP treatment, and vice versa? Is there a preferred method for yourself from your perspective?
Yeah, there's definitely one to myself, and I'm known for this, unfortunately. I don't, letters and things are fine. I just love a voice message. Like, I would prefer if everyone in my life just sent voice messages, everything would get done. Like, I would rather I see a patient, I would rather, be friends on whether it be social media or just text message and just a voice message handover. Of course, it's a bit more professional, and without that great relationship, it's just letters and things like that. But I feel as though you can give so much more nuanced information in a voice message, whereas a letter, you're not going to write a 500-word letter to everyone or a 300-word letter to everyone. I think voice message is the best for me particularly, but in most cases, I think a letter or an email is fine. But you can just give so much more information. You can talk about, patient context, personality, the education you gave to them. Like, if you're trying to say in a letter, I spoke about this, can you reinforce this? And this is how I worded it. It's very hard to do in a letter. Whereas with a voicemail, it's like, yep, we spoke about pain being multifaceted. Your foot type probably isn't the cause, but it may be contributing to your prognosis. Can you reinforce that so they don't have fear and catastrophizing about their biomechanics? Like, that's too hard for me to put into a letter. I'd rather just voicemail it. Yeah, or someone voicemail that to me.
That's absolute gold, mate. I've never heard that before, and it makes absolutely perfect sense. And I think that's just a huge amount of value for thousands of listeners we got out there. I think that might change the way that people update, or at least request, because I'd absolutely love that as well. So easy. And
I probably should clarify, the voicemail is the voice recording, not as in call, I don't answer, you leave a voicemail, like the recording that you send on your phone. I just realized how that comes across.
Yeah, the little microphone button on the text message.
Yeah.
Perfect. All right, excellent. That's so good. So good to know, mate. That's makes perfect sense. And awesome. I think another question. This one's going to be a little bit of a tricky one. We're always, as EPs, wanting to promote ourselves and promote that we can do everything we can to be the best EP in town. And I guess it doesn't really matter if we feel like we're the best. It's really the perspective of others and what that actually means to be the best. So from your perspective as a podiatrist or another allied health professional, what does it take to be the best exercise physiologist in town from your perspective? What does that look like?
Yeah, that's a really, really good question. I guess it would relate to all allied health as well. I think from what we understand with the research, when somebody has pain, a lot of things work. So whether you give, say for an example, someone with hip pain or knee pain, if you give them some squats, if you give them 3 sets of 5, 3 sets of 8, 3 sets of 40, 2 sets of 66, they're probably going to get better. So I think the skill with that probably isn't as important. So if someone's really nuanced with their approach to exercise, like, that's really great. But in my opinion, what makes a good allied health or a good EP is not so much their exercise prescription and that kind of thing, but the communication with the patient, how the patient feels, how they make them feel about themselves. Do they have a good understanding of pain and its multifaceted nature, and their soft skills, engagement with, patients just feeling good about themselves and what's happening with their conditions, and, mapping out a bit of a journey. It comes down to, I guess, patient-centered care. And if a patient says to me, I saw Ryan up at Hunter Rehab, and yeah, it was great. We got a bit of a plan. I really felt like I was listened to. I felt like he explained everything. I've got a good understanding of what's happening with me. I think that for me, that's like that person is a great allied health professional, because that's the most important thing. Is patients feel heard, they feel listened to, they feel like we're in a team. You've got that therapeutic alliance. Like that is just so important. If they have an understanding of what's happening with them, we know that based off the research, we know that leads to better outcomes, better self-efficacy, better health-related quality of life, better prognosis, and a happier life living with disability or pain. Because a lot of the conditions that we both co-treat are, they're chronic and long-standing. There's chronic condition, there's comorbidities. Like these people are more likely to be living with it for longer. So that I guess the better they can live with it, of course, the better they're going to feel. And to me, that's, if someone can make them feel like that, that's a good EP and a good health professional, which is the hardest thing to do. And that's what we're all trying to do. And there's no cookie cutter way to do that, because everybody is different.
Yeah. I think that's such a great answer, mate. I think it's really great answer to a challenging question. It's to summarize how you make them feel. Like that is such an important factor, is how does that person feel? Like we are so tied into emotions as human beings. And I think when we make that connection and we connect with the patient, that's the real value there. Because I just did an episode on this last week that we need to change sort of how we define ourselves as exercise physiologists. We are not experts at prescribing exercise. We are behavior change experts. A behavior change expert is obviously, it ties into the emotions, is great at goal setting, great at building rapport, great at keeping people accountable. There's a lot of things there, because if you look at ChatGPT, it's a probably better exercise prescriber than us now. So it's crazy. It writes programs just as good as us, if not better. Yeah. So if we defined ourselves as that, then we'd be pretty redundant quite quickly. But it's our skill to follow up with people and change their behavior is where the real value lies.
Yeah, definitely. I think, like, back to my point before of, we have so much research and it's only continuing to come out. Exercise and movement is great. It's awesome. We know it's great for everyone, depending on whatever walk of life they're going on, depending on whatever age. Like, I don't think that's the question anymore. It's how do we get someone to engage with rehab and exercise? Like, if you can answer that question, you're going to be a billionaire, because that's the big question that we all struggle with. Is we know what someone needs to do, but how do we get them to do that? And it generally looks like, they feel listened to and heard. They understand why they need to do it, and they have that experience. We know that's one of the best ways of learning, and that's going to lead to better outcomes. Like, compliance is always the biggest issue. I know what you need for your Achilles tendinopathy. We all know what you need, but getting you to do that is almost the hardest thing. And if you can get someone to do that, I'm like, wow, that clinician knows what they're doing, because they can obviously, have that relationship with that patient.
Yeah, 100%, mate. I feel like I could chat for hours about this with you, but I think that's we're just about out of time today. But where can listeners learn more or find more about yourself, mate?
Yeah, my partner, physiotherapist, and I co-host the Sports Medicine Project, which is just a podcast platform where we get sports medicine specialists on. We just had an ACL surgeon come on, people talking about tendons, bone stress injuries, foot athletics, footwear, run programming, diagnosing, that kind of thing. So that's our podcast. And then my social handle is Blake with the Sports Podiatrist, where I just post foot and ankle stuff, but research, just things relating to, I would just say, health, orthoses, pain education, high-end rehab, biomechanics, injury, running, that kind of stuff. So give me a follow, which would be awesome.
Awesome. I'll put those those exact handles and that podcast in the show notes, so we can click on those and follow Blake. But once again, mate, thank you so much for your time. It's been really enjoyable and very valuable as well. So I appreciate it.
Thanks, mate. Love that. Thank you.
No worries. Bye for now.